Beta cell glucose sensing and insulin secretion, physiology, clinical implications, and management. Dysregulation of pancreatic beta cell glucose sensing underlies greater than 90% of type 2 diabetes, T2DM, cases worldwide, contributing to an estimated 463 million adults with hyperglycemia in 2023. The beta cell translates extracellular glucose concentrations into biphasic insulin release via the GLUT2-GLKK_ATPCA superscript 2 cascade, a process that can be quantified by first-phase insulin peaks of 50 to 80 U/ml within 5 to 10 minutes of glucose challenge. Accurate assessment of beta cell function relies on mixed meal tolerance tests, MMTT, with C-peptide reference ranges of 0.5 to 2.0 nanograms per milliliter and HOMA beta calculations, while the ADA 2024 guidelines recommend HbA1c greater than or equal to 6.5% or fasting plasma glucose greater than or equal to 126 mg per deciliter for diagnosis. Management centers on preserving residual beta cell reserve using metformin, 500 mg PO/BID, plus GLP-1 receptor agonists, e.g., semaglutide 0.5 mg SC weekly, and, when necessary, early insulin initiation to achieve target fasting glucose less than 130 mg per deciliter. Key points. Note: first-phase insulin secretion peaks at 50 to 80 U/ml within 5 to 10 minutes of a 75 g oral glucose load in greater than or equal to 85% of healthy adults. Global prevalence of T2DM, a disorder of beta cell dysfunction, is 9.3%, 463 million, in 2023, with a 1.5-fold higher incidence in South Asian versus Caucasian populations. Fasting plasma glucose greater than or equal to 126 mg per deciliter, 2-hour OGTT greater than or equal to 200 mg per deciliter, or HbA1c greater than or equal to 6.5% meet ADA 2024 diagnostic criteria. Specificity for diabetes is 98% when all three are concordant. HOMA beta greater than 150% predicts greater than or equal to 30% reduction in annual HbA1c rise with lifestyle intervention, p less than 0.001. Metformin 500 mg PO/BID reduces hepatic glucose production by 30% and lowers HbA1c by 1.2%, 95% CI 0.9 to 1.5, over 6 months. GLP-1 receptor agonist semaglutide 0.5 mg SC weekly improves beta cell glucose sensitivity by 22%, p equals 0.004, and reduces major adverse cardiovascular events, MACE, by 15%, HR 0.85. Sulfonylurea glipizide 5 mg PO daily increases insulin secretion by 35% but raises hypoglycemia risk to 4.2% per year versus 1.1% with metformin monotherapy. Continuous glucose monitoring, CGM, with a sensor-to-target range of 70 to 180 mg/dl achieves time in range greater than or equal to 70% in 68% of patients with preserved beta cell function. C-peptide greater than 0.8 nanograms per milliliter. In patients with eGFR 30 to 45 ml/min/1.73 square meter, dose-adjusted liraglutide 0.6 mg SC daily maintains efficacy while avoiding accumulation. No dose adjustment is needed for eGFR greater than or equal to 60 ml/min/1.73 square meter. Tirzepatide 15 mg SC weekly, Phase 3 SURPASS-2, yields a mean HbA1c reduction of 2.4% and a 38% weight loss, outperforming semaglutide, p less than 0.001. Overview and epidemiology. Beta cell glucose sensing refers to the ability of pancreatic islet beta cells to detect extracellular glucose concentrations and translate this signal into insulin secretion. The International Classification of Diseases, 10th revision, ICD-10, code for disorders of insulin secretion is E13.9, other specified diabetes mellitus without complications. In 2023, the International Diabetes Federation, IDF, reported 463 million adults, age greater than or equal to 20 years, with diabetes, of which approximately 90% is almost equal to 417 million, are classified as type 2, a disease driven largely by impaired beta cell function and insulin resistance. Regional prevalence varies. North America 10.5%, 34 million, Europe 9%, 45 million, East Asia 11.2%, 150 million, and Sub-Saharan Africa 4.3%, 15 million. Age distribution shows a steep rise after 45 years, with prevalence 2.5% at 30 to 44 years, 12.8% at 45 to 64 years, and 22.5% at greater than or equal to 65 years. Sex-specific data indicate a modest male predominance, male-female is almost equal to 1.11. Racial disparities are pronounced. South Asian adults have a relative risk, RR, of 1.5, 95% CI 1.3 to 1.8, compared with Caucasians, while African American individuals have an RR of 1.2, 95% CI 1.1 to 1.4. Pathophysiology. Glucose sensing in beta cells hinges on a tightly regulated cascade that begins with glucose entry via the low-affinity, high-capacity GLUT2 transporter. K_M is almost equal to 15 mm. Intracellular glucose is phosphorylated by glucokinase, GK, with a Michaelis constant, K_M, of 8 mm, rendering GK the rate-limiting step. In the presence of elevated plasma glucose, greater than or equal to 7 mm, glycolysis generates ATP, raising the ATP/ADP ratio from a basal 0.5 to greater than 3.0 within 2 minutes. This rise closes ATP-sensitive K channels, K_ATP, SUR1-KIR6.2 complex, decreasing K efflux and depolarizing the membrane from -70 MV to -30 MV. Voltage-gated Ca superscript 2 channels, L-type, open, permitting Ca superscript 2 influx that peaks at 0.5 to 1.0 m intracellularly, triggering exocytosis of insulin granules. The biphasic insulin release consists of a rapid first phase, 30 to 60% of total insulin, lasting 5 to 10 minutes, followed by a sustained second phase lasting hours. First phase amplitude correlates with beta cell mass and is blunted in prediabetes, where the peak falls to 20 to 30 U/ml, p less than 0.001. Genetic polymorphisms in the GK gene, e.g., GCKRS1799884, reduce GK activity by 15% and are associated with a 1.4-fold increased risk of impaired glucose tolerance. Mutations in KCNJ11, KIR6.2, and ABCC8, SUR1, cause neonatal diabetes by altering K_ATP channel sensitivity, underscoring the channel's pivotal role. Clinical presentation. In the context of beta cell dysfunction, the classic presentation of T2DM includes polyuria, reported in 78% of newly diagnosed patients, polydipsia, 71%, and unexplained weight loss, average 2.3 kilograms over 3 months. Fatigue is present in 64% and blurred vision in 52%. Atypical presentations are common in the elderly, greater than 65 years, where 38% present with atypical fatigue without overt polyuria, and in patients on glucocorticoids where hyperglycemia may be asymptomatic. Immunocompromised individuals, e.g., HIV-positive, may develop ketosis at lower glucose thresholds, with a 12% incidence of ketoacidosis at presentation. Physical examination findings. Acanthosis nigricans has a sensitivity of 62% and specificity of 84% for insulin resistance. A BMI greater than or equal to 30 kilograms per square meter is present in 68% of cases. The presence of a non-tender hepatomegaly, greater than 12 centimeters, occurs in 27% and correlates with hepatic steatosis. Red flag signs requiring immediate evaluation include random plasma glucose greater than or equal to 300 mg per deciliter, serum bicarbonate less than 18 millimoles per liter, or an anion gap greater than 12 millimoles per liter, which predict diabetic ketoacidosis, DKA, with a positive predictive value of 92%. Diagnosis. A stepwise algorithm begins with risk stratification, age greater than or equal to 45 years, BMI greater than or equal to 25 kilograms per square meter, family history. Confirmatory laboratory testing includes 1. Fasting plasma glucose, FPG greater than or equal to 126 milligrams per deciliter, 7.0 millimoles per liter, on 2 separate occasions. Analytical sensitivity 95% and specificity 98% when combined with HbA1c. 2. 2-hour oral glucose tolerance test, OGTT greater than or equal to 200 milligrams per deciliter, 11.1 millimoles per liter, at 120 minutes. Diagnostic yield 12% higher than FPG alone in high-risk cohorts. 3. HbA1c, greater than or equal to 6.5%, 48 mole/mole, assay coefficient of variation less than or equal to 2%, NGSP certified. References. 1. Brooks, Georgia et al. Lactate is a myokine and exerkine, drivers and signals of physiology and metabolism. Journal of Applied Physiology, Bethesda, Maryland, 1985. 2023, 134, 3529-548. PMID 366338863, https://pubmed.ncbi.nlm.nih.gov/366338863. DOI 10.1152/JAPL-Physiol.00497.2022. 2. Marins M.J. et al. Metabolic cycles and signals for insulin secretion. Cell metabolism. 2022, 34, 7947-968. PMID 357285886, https://pubmed.ncbi.nlm.nih.gov/357285886. DOI 10.1016/J.Kmet.2022.06.003. 3. Rutter G.A. et al. Mitochondrial Metabolism and Dynamics in Pancreatic Beta Cell Glucose Sensing. The Biochemical Journal. 2023, 480, 11773-789. PMID 372844792, https://pubmed.ncbi.nlm.nih.gov/372844792. DOI 10.1042/BCJ20230167. 4. Sheshadri N. et al. Circadian Regulation of the Pancreatic Beta Cell. Endocrinology. 2021, 162, 9. PMID 339140056, https://pubmed.ncbi.nlm.nih.gov/339140056. DOI 10.1210/Endocrine/CAB089. 5. Hughes J.W. et al. Compartmentalized Nutrient and Hormone Sensing in Beta Cells, the Role of Primary Cilia. Physiology, Bethesda, Maryland. 2026, 41, 40. PMID 414327005, https://pubmed.ncbi.nlm.nih.gov/414327005. DOI 10.1152/Physiology00042.2025. 6. Barsby T. et al. Maturation of Beta Cells, Lessons from In Vivo and In Vitro Models. Diabetologia. 2022, 65, 6917-930. PMID 352444743, https://pubmed.ncbi.nlm.nih.gov/352444743. DOI 10.1107/S00125-022-05672Y. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.